It's my pleasure to introduce our speaker tonight, Kim Callinan, who is an accomplished nonprofit leader, motivational speaker, best-selling author, and expert in organizational management. She's also an expert in cultural intelligence and end-of-life care. As the CEO of Compassion and Choices, which is the nation's largest nonprofit organization advocating for patient-direct end-of-life care, Kim has led efforts to ensure that individuals have the information, tool, and know-how to embrace the life's transient nature so that people can finish strong. And so without further ado, again, it gives me great pleasure to turn it over to Kimberly. Thank you for joining us.
Wonderful. Well, I just want to thank you so much to Judith and to Chris for inviting me today to be a part of this. It looks like there's a great group of people that far surpassed expectations. So thank you to all of you who showed up today to this presentation around living and dying with dementia. I know that for some of you in this room, it's a deeply personal issue, and I hope that I'm able to offer you something that um, is meaningful for you so that you leave today with just a little bit more information and know-how around really how what your options are around dying with dementia. Obviously, we all hope for improved care, and we all hope for greater focus around treatments, and that there eventually one day will be a cure. But no matter what happens, all of us at some point will die. And so understanding our options around dying with dementia are important. So I'll start off with just a little bit about compassion and choices. Our mission is quite simply to improve care, expand options, and empower everyone to chart their end of life journey. And what we see in our work is that when people embrace the inevitability of death and the end of their life, that they live each and every day with far more empowered, with greater meaning. And so hopefully people will be able to, through mortality awareness, not just improve down the line for whatever point somebody dies, but you're able to improve how you live your life each and every day. We have over 500,000 supporters, about 85,000 donors, 7,000 volunteers, and lots of people taking online actions because our mission covers both the legislative side of work, the system side of work, as well as the personal empowerment and education side of end of life care. And we have kind of a full gamut of services that we provide, from grassroots outreach to legislative advocacy. But today's focus will be around dementia. And I want to start first with a story that is what helped make this work so important and meaningful for me. And that was the story of my grandmother. She's on the left there. She had dementia for 10 long years. And during the early parts of her dementia, um, she was she danced with my father. She actually had a delightful personality. And we had many really meaningful, memorable times together. But eventually, after 4 or 5 years, she hit a point of advanced dementia where she was unable to communicate to the people around her. She was bedridden, and she had what I would consider for myself not a lot of quality of life left. She was in kind of a trance, and that was kind of the experience day in and day out with very little recognition. And while I was visiting her, one of the things that I was young at the time, this was before my work at Compassion and Choices, by many, many years. I was in my 20s. And oh, I guess I was early 30s. And I guess I was sort of a little naive about what would happen with dementia. And I sort of thought that if I gave my grandmother spent her whole life asking me for a grandchild. And so after my son was born, I thought, "Oh, I'm going to bring my son Trey and I'm going to put her in my grandmother's arms. She's going to snap out of this trance and all's going to be well again." And of course, there was not a happy ending to that story because she had no awareness of my grandson, no awareness of me, and it was pretty much the experience that it had been. At the same time, she ended up with an infection, and my mom went ahead and treated the infection, and we went on doing what typically happens within end of life care, which is you treat and you occur. And I remember sitting in my chair at that moment and thinking to myself, I wonder if this is what Nana would want. And I asked my mom, is this what Nana would want? And my mom kind of looked at me and just kind of brushed over it. It was what you did. You treated. And we never had that conversation with her, but fast forward 20 or 30 years, and as I started to get into this field, and I really started to realize that how one is cared for with dementia, there is a range of options that can be chosen from, but that the default mode within our healthcare system doesn't recognize that. You go into automatic treatment, and that may in fact be appropriate in what the person wants, but the key is, what would the person want? And that's part of the work that we do. This was my son at the time when I put him in her arms. And as you can see, there's not a lot of awareness. Um, at the same time, fast forward 30 years later, and I end up leading the largest national organization that does work around end of life care and planning. And the issue of dementia is still, deep in my psyche, around something that I feel like as a country we need to do more around. And this article comes up, and I'm already doing work in the field by this point, but I thought it was such a poignant article. It was by a gentleman named Dr. Jeffrey Hosta, and he's an emergency room physician for about 30 years. And it's called Doctors Are Torturing Dementia Patients at the End of Life, and it's totally unnecessary. And he shares the story about an 88-year-old woman who had advanced dementia, didn't recognize her surroundings, had no awareness. She ended up having a medical crisis. She got rushed to the emergency room, and the family was insisting on all available care. So she got her ribs broken so she could be resuscitated. She got tubes put in. She went through pretty grueling invasive procedures for several hours, and then she died anyway. And I thought he did such a powerful job of outlining the ethical challenge of the default mode within our medical system of overtreatment. And this is, while I would say is was a very, there's a range of possibilities. This particular range being on one end, about a quarter of people who with advanced dementia end up in the emergency room at the end of their life. So it's not that out of the realm of like, this is what's typically happening within end of life care. And so it raises the question about, why is that happening? Is that what the person would want? And what could we do in order to have a different outcome if that's not what we would want? We know that 57% of adults with dementia had at least one emergency room visit in the last month of their life. Of course, with advanced dementia, so if you're in the last month of your life, removing of a person from their home in and of itself is a traumatic experience for most people with advanced dementia. So really what you would want is the person to be able to die as comfortably as possible in their own surrounding would be the most humane way for somebody to die. So the idea that over half of people are ending up in an emergency room the last month of life, is something that for me is pretty stark. 4 in 10 hospital stays for adults with dementia are avoidable. So we're again moving somebody into the hospital when that's an entirely avoidable situation. And I think what's most noteworthy for me is that the treatments are inconsistent with what most people say they want at the end of their life if they have dementia. So we have done surveys that look at what people want around dementia, and about 80% of people with advanced dementia say that they would not like any treatments that prolonged their life if they were in a state of advanced dementia. But we're doing both treatments that prolong life, and we're doing aggressive treatments in many instances. 93% of people feel it's important to have an advance directive, yet only 37% have completed one. 12% haven't shared it with their doctor. 73% want to stop life-prolonging treatments if they're living with dementia. And the reality is, even if people were doing their advanced care planning, the vast majority of advanced directives and advanced care planning don't even address what one does with dementia. So, you could fill out the most extreme situations of I don't want to be resuscitated through an advanced care plan, but there's so many other treatments that are taking place that people aren't really thinking about or making decisions about. Um, with advanced care planning, it promotes patient-directed care. It decreases aggressive treatments from taking place if that's not what the person would want. It reduces burdens on the family from having to make really difficult and challenging decisions without having proper information about what the person would want. It decreases hospital admissions and the length of stay, and it improves the overall patient experience. So advanced care planning is a win-win. However, standard advanced directives don't address the complex and unique needs of people with dementia. And that is why we at Compassion and Choices created a dementia values and priorities tool. And our values and priorities tool, you can do at any point. So you want to do this in advance of a person getting dementia or in the early stages having dementia while the person is still capable of making their own healthcare decisions. And the Dementia Values and Priorities tool basically gives people a customized care plan that their healthcare proxy can follow around what kind of care they want to receive and don't want to receive should they end up with dementia. It focuses on the common types of outcomes that someone has with dementia. So the factors might be, I don't recognize my loved ones, I can no longer get out of bed, I can't carry on a conversation. You can also create your own traits of what's your line in the sand for you. And then you can pick 3 different levels of care. So you can pick, I want all available care. Keep treating me, keep making sure that I'm staying alive, do everything possible. There's a middle level of care that is, I don't want aggressive treatments, but I do want you to keep giving me treatments for whatever conditions there are that are, whatever other conditions I have. So if I have diabetes, I want my diabetes medication. If I have heart disease, I want that. If I get pneumonia, I want to get treated, but I don't want to be resuscitated. I don't want to go to the hospital. So that's kind of the middle level of care. And then the last one is I want you to look for natural exits to allow me to die as peacefully and quickly as possible. And I think we live in this false dichotomy that there are no options if you have dementia within our healthcare system. And the reality is that we are actually artificially extending the length of time that people live with dementia through medical interventions. So if you think about how long somebody, how people used to die, they died from diabetes, from dehydration, from diseases, but now we've gotten really good in medicine. We've got heart medication, we've got, treatments for pneumonia, we've got treatments for bladder infections, all the things that used to allow a person to die, we can now treat. And within medicine, even when someone has dementia, we're still treating those things. So the question becomes for the person, if my mind has gone, and at what point has my mind gone, do I still want to extend my body? And that's what this tool allows you to do. It allows you to really think about the point at which you would want to do that. You would want to make different decisions if that's what you want. And there's no judgment in the tool. There's no right or wrong. For me, the tool's been really interesting doing it with different people, because what I have come to realize is 2 things. One is that it's far harder for people to really think about and be thoughtful about, what do I mean when I say I don't want to live with dementia, or I'm afraid of it, or I get it? Like, what is your line in the sand? And then how different that line is for different people. So my mother, when I did it with her, she is pretty far along. Like, she wants to keep being, kept alive and cured and treated, and, for a pretty long time. My dad, on the other hand, is very much like, if I lose my mind, that's everything to me, and I would want you to find natural exits for me at that point. And I think the filling out of the tool, what I have heard many people say is, God, these are really hard decisions. I don't know what I would want. Like this is really complicated. And what I would say back is if you don't know what you would want for yourself, then imagine how difficult caring for you will be for your loved ones. Because as somebody who loves somebody else and is taking care of them, it's incredibly difficult to imagine choosing not to treat, pneumonia if that person hasn't been really clear that that's what they would want. So I think of this tool as a gift, not just for the dying person, but for those that are left behind. Um, the other thing that's really important with all advanced care planning, but especially for somebody with dementia, is having a really strong healthcare proxy. And I know as caregivers, many of you, I understand, are caregivers. You experience the challenges within our medical system on fighting to make sure you're getting the right care and all available care. And the same is true when you're trying to carry out an advanced directive. If a person is ready to not accept treatments, you are up against a medical system that really is geared towards saving lives. And the concept that this person might want something different in this moment is a really difficult one for people to get their arms around. So choosing the healthcare proxy is extremely important. Often people will default to their closest loved one. And many times that's appropriate. I don't want to start World War II in any family. But I will say sometimes it's not the spouse or the partner is not actually the best healthcare proxy, and that it's worth a thought and a conversation about it. And this actually came up with my mom and dad, where my dad chose me to be the healthcare proxy. And when I asked, this was before I worked at Compassionate Choices, I knew nothing about end of life care. And when I asked him why he chose me, he said, because I know your mom would never carry out my wishes. Her focus is going to be on being unable to say goodbye to me. And I'm going to be ready to say goodbye before she's going to be ready to say goodbye. And I know you're going to make the decision that I would want. So I thought that was pretty intuitive of my father to recognize that 30 or 40 years ago. What I see within my work all the time is people not recognizing that and the partner having a really difficult time. That's, again, it's not everyone. It depends on the person, but it's something to think about as you're choosing your person. The other thing that's really important is picking somebody who is really able to go up against the power system. You want a strong advocate, someone who's not afraid to speak up and to take on, challenges and make difficult decisions under pressure. The third thing that's helpful with the proxy is somebody who can get the family and the loved ones all in line. Because one of the things that does happen a lot at the end of life is if there are disagreements among the family, the medical system often chooses the person who wants the most care, which in many instances may be appropriate, but oftentimes in this situation may not be, based on what the data shows. And so having someone who really is able to kind of bring people together is really important, both to make sure that the dying person is getting what they want, and also because it's always an unfortunate situation when a death causes a fracture in the family. And unfortunately, that happens much more often than I wished it did. After you fill out your dementia values and priorities tool, it produces a customized advanced directive for you. You want to be sure you share it with your healthcare proxy, and you want to then share it with your friends and family. And sharing it with the friends and family and sitting down with them and having a conversation about it is extremely important, because that's what helps make sure that everybody is aligned, and that increases the likelihood that you will get the kind of end of life care that you want. We also encourage you to take a video after you have filled out the advanced directive of what it is that you want, so that when people are having debates about it, they can refer back to the video and hear you in your own words, being really, really clear about what your priorities and values are. The next step would be to make sure that you find doctors who are willing to honor your values and you educate them about your values. If you happen to be on Medicare, you are eligible for an annual advanced care planning conversation. And I really do encourage people to take advantage of that and call and specifically schedule a conversation with your healthcare provider. Bring a copy of your advance directives, bring a copy of your dementia addendum, and review with them what it is that you're looking for at the end of life. Or if you're the caregiver, what your loved one said was that they wanted, if they were still competent at the time. And make sure that you find providers who are willing to honor what you want. Um, there is a range of providers. There are providers who have moral objections to certain things that people want. And so this is really important. You'll see on this page, we show an end of life wishes letter to medical providers. This is a part of our end of life decision guide, which is a free toolbook that's available on our website. And that's another way that you can give it to the doctor to help you if you're uncomfortable opening up the conversation, and let them read it while you're sitting there, and then use that as a conversation starter. We also encourage people to ensure that the facilities that they're at are willing to support their values. We have a number of addendums to advance directives, everything from a rider to a residential assisted living facility to a sectarian healthcare directive to a hospital visitation form on who you do want to go to the hospital and who you don't want to give permission to visit you at the hospital if there happens to be people like that. But if you live in a residential facility, it is important that you talk to them if your medical care is provided through them, that you talk to them about what's important to you at the end of life, so you don't end up in the emergency room if that's not what you would want at whatever point in time you're there. And then we have one last tool called the Dementia Decoder. And this provides you with a series of questions that can be asked to your doctor. So if you're the caregiver or if you're in the early stages of dementia, it allows you to produce a set of questions when you meet with the doctor to get all information about the available treatment options and what it is that you want. I think all too often people will default to doing whatever the doctor says should be done, and many times that's appropriate, but sometimes the values that you as a patient have may be different than the doctor's values. Sometimes you might want more care, sometimes you might want less care. And so it's important that your values are leading any conversation, and the decoder helps you to know what questions that you ask. A great example of this actually happened. We have a dementia decoder, but we have one around other illnesses as well. But if you think about dementia and the situation I raised earlier with my grandmother, if I had been where my grandmother was with her advanced dementia, my dementia directive has that I would not want the infection to be treated. I would want to be kept comfortable. So those are the kinds of questions that you would ask. Is this treatment that you're providing to keep the person comfortable, or is this treatment that you're providing going to prolong their life? So those are the kinds of questions to ask the doctor. What are the burdens of the treatment? Like, what will happen at the end of that treatment? That will I return to my pre pre-disease self, or does the treatment that I'm taking have some type of a consequence to other aspects of my quality of life? So the decoder gives you a series of questions that you can ask for your doctor depending on the care that you're looking for. And the important thing to remember with that is that there is no right or wrong answer. There are just your values. And so the work that you do to define what your values are is really important. This is our website, compassionandchoices.org. And under Plan Your Care, you can find all of the tools that I've talked about. So again, it's compassionandchoices.org. We have a free end of life decisions guide, which you can add your address in and it gets ordered, comes to you in the mail. It's about 40 pages and it takes you through figuring out what your values are so that you can fill out your advance directive. And as importantly, your healthcare proxy really understands what your values are. We have our dementia values and priorities tool and the dementia decoder. All can be found under the Plan Your Care section of our website. And that's it. I will stop sharing my screen and open things up for questions.
All right, thank you so much, Kim. For anybody that has any questions or comments, I would encourage everybody to type them out in chat and I will relay them to Kim. So I actually have one question. In my experience, having an advanced care planning session is really important, particularly in getting, certain documents done, like the healthcare proxy, durable power of attorney. Can you just maybe speak a little bit about, your guys' process in terms of how, what considerations you take when you're speaking with a family for the first time? Are there any challenges that you tend to face? Anything that you are looking out for in terms of, working with the family that might be in a very vulnerable position?
Yeah. I think well, first of all, remind me to talk about pulse as well, because I think that's an important part of a conversation for anyone with dementia. But I think in general, it really depends on how I engaged in the conversation with the person. So most of the time, the people that I'm talking to are highly motivated, and they're just wanting to understand what are my, what do I do? How do I get what I want? Or they're highly motivated and they're not sure how to broach the topic with their loved one. So I think to start with, the thing that I try to do is help the person to understand what their values are. And I think that in and of itself, it seems like it's a really, like, on the surface level, it seems like, I'd say the most common thing that people say to me is, I don't want to live with advanced dementia, like, no matter what. They say, I don't want to live with dementia no matter what. But when you really start talking to them about it and you say, well, when my grandmother had dementia in her early stages, she had 4 or 5 years where we still had great conversations and she danced and she was smiling and she was singing. When you say you don't want to live with dementia, is that what you mean? Oh, no, no, that's okay. So I think what I try to do is really help the person to understand that this isn't like I have dementia, I don't have dementia. There are many, many, or can be many, many, many meaningful years and moments with dementia. And so I try to empower people to understand that what you want to do is understand what are your values, what's your line in the sand for what quality of life looks for you, and define that clearly, because that's going to help pave the way for what kind of care you want to get and what kind of care you don't want to get. And then the second piece is, once the person is clear themselves on what it is that they want, then there's a lot of alignment to happen with the family, because it's really difficult for a family to think about the concept of, I'm going to take away my mother or father's blood pressure medication, or I'm not going to give them their diabetes medication, or you want me to let them die from pneumonia when there's treatment for that. Like, that is counterintuitive to the way we've all been raised. And so if that is what you want, then you really have to do some pre-work to be sure that the people around you are going to support you in that, if that's what you want. And then if you want all care, you also want to be sure that people understand that, because the hardest thing for a caregiver, a loved one, the person in the position, is knowing, how do I show love for this person? And if you haven't told them what love means for you, if you end up in that situation, they're just guessing, and it ends up resulting in a tremendous amount of guilt. And I think for the vast majority of people, it really it's a very challenging conundrum for them.
Sure, thank you.
Yeah.
Uh, s- so
The
I have.
material. Oh, sorry, you're going to read them to me. Go ahead.
Oh yeah, yeah, yeah. There's a question from Dan in the comments. Dan asks, if I'm not at imminent risk of dying, oop, sorry, it just escaped from me. If I'm not at imminent risk of dying, can hospice or treater, I'm assuming you mean provider, simply provide pain medication and water and allow me not to eat anything?
So that is a great question, Dan. So if you are mentally capable, so you still have the capacity to make an informed medical decision. You can choose to voluntarily stop eating and drinking. It's typically, you can do that and then enroll in hospice care if you're not yet eligible for hospice care. And we have several videos on our website about it and some brochures that go through the process with you. It does take, depending on the person, 7 to 9 days to die that way. So it's not an immediate solution, but if you're mentally competent and you know that you don't want to continue down the dementia path, that is a legal option for people. It will require you to find a supportive hospice and supportive providers because you want to be doing it with pain medication. And I would start by looking for non-religious hospices in your area. The religious hospices, or in particular the Catholic hospices, I think uh, follow ethical and religious directives and normally will not honor the process of VSED, but in a non-religious hospice, often you will be able to find support. If you are farther along and you no longer have capacity, um, what is allowed, but it will take a strong healthcare proxy advocating for this, and you would want to have it documented that this is what you want, both in paper and also yourself saying it, is the nursing home facility could bring the food to your mouth, and if you don't like show signs of taking it, you could stop them from force feeding. What typically happens now is there's a lot of force feeding that takes place within facilities when actually the person is like ready to die and they're trying to die and they're getting force fed. And it's a natural reflex that's taking place. So there are facilities that will not mandate forced feeding, but you do have to put it up to your mouth. If you're at home within a hospice that's coming to your home, you may have a little bit more options in that regard because it is a gray area of the law.
One question I have just based on that, you bring up the subject of capacity. In your experience, how typically is that assessed? And where does the line get drawn in terms of whether a person does or does not have capacity?
So it's done by the provider, the healthcare provider, and the capacity is whether they understand the impact of their healthcare of the decision that's being made. So it's done through a visit, and doctors perform capacity assessments all the time. So it's a routine part of treatment. If the person understands the consequences of their decision, then they should have capacity. If they no longer understand the consequences of their decision, they don't. And you do have people who are ebbing in and out with dementia, obviously. So, it could be a matter of when the conversation is taking place. So if they're really clear and level-headed in the morning, and they haven't filled out their advance directive and they haven't done this work, but there are periods where they still have capacity, you should have them do that while they have capacity and can make decisions for themselves and get a video where they can articulate what they want. Because if they don't have capacity, then it's harder to get you're left without that information.
Gotcha. Thank you. Judy says the tool seems excellent. Does the tool itself ask the question, what is important to you?
The tool gives you a bunch of measures of things, and then you rate the level of care you want. And then there is a open box where you can type in anything else you want. So if the questions that like the lines in the sand that we selected aren't what's important to you, you can come up with your own. We actually originally, this is our, I think, version 3.0. We originally had like 25 different options because everyone had different lines in the sand and people came back and was like, that was way too complicated and overwhelming. So we narrowed it down. I think there's 10 questions now, but there is an open field. So you'll be able to put whatever is important to you in that open field.
Great, thank you. Uh,
Can
Chloe
I
asks,
talk about Pulsed for a second? Because I'm pretty
oh
sure
yeah, sure, go ahead.
Pulsed. So, I don't know if people are familiar, but there is something called I don't know if it's a MOLST or a PULST in Massachusetts, but a physician's order of life-sustaining treatment or medical order of life-sustaining treatment. And it's similar to an advance directive, but different in that it's an actual medical order that you work on with your doctor, and it carries a lot more weight. Anybody who is in the early stages of dementia, or actually any serious diagnosis, I would strongly encourage you to work with your doctor to have a MOLST put in place. And you can bring our fill the values and priorities tool out and bring it with you to your doctor's visit and see if they'll incorporate some of that information into your MOLST or POLST. And it actually is in effect not only when you can't speak for yourself, but it is guides the kind of medical care that you're getting. So it carries a lot more weight because it's a physician's order versus an advance directive that's done like very far in advance. So definitely for someone who has dementia or is in the early stages, you wanna make sure that you get a MOLST in place around your end of life care.
Yeah. In Massachusetts, it is referred to as a MOLST. The only difference between the two being that, instead of physician order for life-sustaining treatment, it's medical order for life-sustaining treatment. But yes, I agree, very important. Chloe asks, thank you for this great framework and resources. Are there resources on compassionate choices that may accommodate conversations in a person living with dementia, coupled with an intellectual disability, for example, Down syndrome and dementia, autism and dementia?
Yeah. So that is a great suggestion, which I'm going to bring back to the team. We do not have those resources right now, but I do think that is a really great suggestion, and I thank you for raising it.
Yeah, I think that'd be a great resource to have, particularly given the high prevalence of dementia in those specific populations. So glad to hear that that is, something to be focused on. Maria asks, what are the symptoms or signs that it's time to request hospice care? Or
So I
more specifically, I'm sorry, more specifically, what are the signs that it's time to contact hospice when the patient has a memory disorder?
so I think if I would flip it the other way, and if you have done um, the values and priorities tool, the person is going to tell you what their lines in the sand are for when they're ready to look for a natural exit. And I would be contacting hospice care at whatever point they say this is my line in the sand based on what the values and priorities tool shows. Because now hospice may not yet accept them, but that's when you would want to start having the conversation with them, because ideally what they're saying to you at that point is, I don't want to continue curative treatment. I want to look for as quick an exit as possible. And so you would want to get them into hospice care as soon as possible. The reality with dementia and hospice care is that there really is not a great standard, and every hospice care uses different factors for determining whether or not somebody is eligible. So I would encourage everybody, Massachusetts and Boston in particular, is an area that has great palliative care, and palliative care happens at the onset of a serious diagnosis. You do not have to be dying, and it can be incredibly beneficial to anybody who has dementia because it's focused on treating the symptoms the person has. It's not focused on curing the disease. So as a first step, at any point, I would encourage you to ask proactively about about palliative care and whether that is available to you in your area, which I can tell you in Boston, you have some excellent palliative care options. And so hopefully you would be able to get that for somebody with dementia. And then the palliative care team would be able to help you figure out when is the appropriate referral point to hospice care. Hospice care typically, and palliative care doesn't have a federal benefit. So what's hard about palliative care is you can have excellent palliative care and it's called the same thing as not excellent palliative care, and what you get in one place is entirely different than what you get in another place. So you do want to really shop around if you're looking at palliative care for what does that provide to me. Hospice care is a standard federal benefit. So if you're getting hospice care, there's a set of services that you are guaranteed to get, which includes things like bereavement support and caregiver support, and it depends on the level of care, like where the person is in the dying process, on what level of care you get. However, hospices can always provide more than the basics. So it is also beneficial to search around for different hospice care and see what provides the most benefit for the kinds of services that you would want.
I would also say that if there are concerns, it's always a good conversation to have with one's primary care. It's an ongoing conversation regardless of whatever the outcome is. Uh, Oftentimes patients undergo a, hospice consult. They may not, be accepted at that time, but it's something that at least, the process is ongoing and, the referral can always go back to palliative care if they get rejected from hospice. Amy asks, where do you submit or file your advance directives?
Such a good question. So we encourage people to submit them as many places as possible. So you want your primary care physician to have them. If you have a care physician, whatever your local hospital is, you would want to see if they will take them. You want to have it hanging on your refrigerator. You want to, there is a national advanced care directive that I have mine in. I'll be honest in that I don't know how many hospitals are really looking at it, but it's there just in case. So you really want to you want to give it to as many places as possible, and as many doctors as you have. So just carry it with you and keep giving it to all of the doctors in the hopes that you're increasing the likelihood that it will be there when you need it. And also carrying copies around with you and making sure your proxy has it. We unfortunately do not have a great system right now. It's not a universal system around advanced directives. That's one of the things that we're looking at as a part of our federal policy agenda. Us and others are advocating to have a more streamlined system, but unfortunately, our healthcare system doesn't talk to each other, even in the great year of 2024. And so, you guys may. I'm not an expert on Boston, except to know that you have better medical care than many, many other places. So you might actually have health systems that talk to each other more than other places do. And Chris, I don't know if you know whether they've actually connected the various different healthcare systems there.
So yeah, I think that this is a subject that comes up a lot in my work actually. Typically when I meet with a family for a consult for the first time, it's one of the first areas that I explore is, what advanced care documents have been completed and where are they? I would say about 4 times out of 5, the family reports to me that, yes, they have actually indeed, completed those documents, whether it's a healthcare proxy, power of attorney, MOLS, whatever the case may be. When I go to look at the patient's chart, they are non-existent, meaning that like either that there was a miscommunication or the files just didn't make it into the chart itself. And so what I tell the families is that it's great that you've got those documents completed. It, I can't see them, meaning that if there were to be a situation where, there need to be decisions made, it makes it tougher, to have, to make those decisions, based on the patient's wishes if nobody can see the documents. So there are a couple of different ways to get, these documents. And I think that by and large, it depends on the system. For example, if I were to try to see about, somebody having documents in a Leahy system, I don't have ready access to that. If they're within partners, you know, within the various different hospitals and systems, it's more likely that if they were scanned or uploaded in any one of the sites, then they make it somehow to the chart. But it's not always a guarantee. I can tell you the number of times that I've talked with families and that, yeah, I gave it to my primary care provider and they told me that they were going to get it uploaded in the chart. And again, same thing, just doesn't exist. So they, what actually happened to the documents is unknown. But what I tell them is that, look, bringing attention to it, I think is the best way to sort of remedy it. And in my line of work, I try to, directly get those documents if they're made available to me, and sort of circumvent the system and mitigate the risk of, that same process happening again, where they go through, they submit the documents, and then it just disappears. So, like you said, it's not a perfect system by any means. I wish there was a central, document, place to kind of pull from. Um, but my guess would be that that would be a significant work to be done on a state level. But
There's also not a great system for transferring across state lines. So some states accept advance directives from other states, some states don't.
Mhm.
And so that is another thing, that if you're living between two states, you want to make sure that you have done the advance directives in both states, or that you verified whether the advance directive that you're using in one state will be honored in another state.
Correct. Yeah. It's a system that, is long overdue for some significant improvement.
That is very true, Chris.
Yes. But on the more positive side, once they're in there, there is a system within the partner system where there is actually a specific advanced care directive section that is easily seen. And especially it comes in handy when they're, in an emergency situation, like during an emergency hospitalization, ambulance ride. That's one of the first things that they go to, is a section that has those documents uploaded. And as long as they're uploaded, they can be, seen and verified very quickly. But it's all about getting the actual documents in there in the first place. And I think that's the greatest challenge. All right. But excellent question and a very good topic of discussion. So moving on. Bill asked the question, how would a patient demonstrate at the time of the video or signing documents that they have capacity?
So there are witness attestations with the documents. So you should have witnesses that are signing it to say you have capacity. One of the reasons that we recommend a video is that, through the recording of the video, it's usually fairly clear whether or not a person has capacity and understands what they're saying and doing. And so the video is a great second thing. If you are early enough in the process and you want to like triple sure, some states require notary and some states don't. But getting it notarized would be a way to just like triply be sure that that you've got that kind of seal that this was something that was done. So you could do it notarized as well.
All right. Dan, as a follow-up to his question earlier, just wanted to say this has been an absolutely superb presentation and on target with one of my most critical concerns as a person with early stage Alzheimer's and Lewy body disease. So, Dan, I'm very happy that, our conversation tonight has been helpful.
And I did see, I think I saw there people asked whether there was a charge for these, and they're all free. We're a nonprofit. It's about getting the tools and the information out to people. There's no cost.
Right. And then there's another question here. Janet asked, does the MOLS have to be updated every year? I can actually take this one if you'd like. The short answer is no. Basically, the way it works is it's sort of a what have you done for me lately type of system where the most recent document, supersedes the other, assuming that capacity is retained and, all those concerns are mitigated. So if you want to change, a particular form, whether it's healthcare proxy, power of attorney, most forms, it can be done. And the most recent document, supersedes the previous ones.
And
So,
we usually say you may want to consider proactively updating your form if there's been a change in health status or you've changed providers. So it does not have to be updated annually. It carries forward, but it's not bad to review it annually. And certainly if you've had a change in your health status in any way or your providers, it's a good time to update.
all right. And then Jen also asked the question, are comfort care and palliative care the same?
So they are terms that are used interchangeably. I used to refer to it as comfort care, but people who work in the palliative care field got very upset with me, even though I think comfort care is easier for average people to understand. But the two terms are used interchangeably.
I would also say one qualification for palliative care as well is there's a significant shift in focus to quality of life as opposed to curative medicine, where, especially in things such as like pain management, that comes up a lot. And I think that's where you know, oftentimes I get, the concern of like, I've been referred to palliative care. Am I dying? And no, not necessarily, but there was expressed concern for the quality of life and what we can do to sort of maximize that quality as opposed to just focusing solely on the treatment aspect, because there's a whole host of, things that, to explore from just that aspect of medicine.
Yeah. So I think just to kind of reinforce what you were saying, Chris, I think sometimes when people think of comfort care, they're thinking of hospice care where you're not getting treatment alongside. Whereas with palliative care, you are getting the comfort care or the care around your treatments, but you also can continue to get treatment for your curative disease, to cure your disease. So
Right.
I guess that is why the interchanging of the terms, while often people do use them interchangeably, I don't think the palliative care community likes them to be used interchangeably for that reason.
If I had to guess, I think it's because palliative care, does get that sort of automatic connection with hospice, and there is a distinction with it that, we want to try to clarify. So, all right. So Conrad, sorry you were late, but Conrad asked, how do we get these documents? I would be very interested to know which documents you're referring to. I think that for the documents that Kim was presenting today, they will be made available via the presentation that she had. If you're talking about the documents like healthcare proxy, power of attorney, or most, power of attorney is usually done with a notary or a lawyer. Healthcare proxies can be obtained in most healthcare offices. I mean, usually people get it through their primary care office. Most forms as well are usually ready on hand, either in an inpatient setting or again in the primary care office or online.
On our website, if you go to the plan your care section, and then you can go down to a part where you can select your state, it links to the Massachusetts state forms for all of them except for most, which you would which your doctor would do with you. So you can get like the healthcare proxy and your advanced directive forms and all of that.
Yep. Okay. Yeah, so yeah, the link to the site is there, so I would encourage everybody to go take a look at that if you have any questions on that. Are there any other questions or any thoughts that anybody's had? Please feel free to put them down here in the chat. Um, I'm curious, Kim, just to know, given your wealth of experience in this area, has there been any case that you are willing to, talk about that has stuck with you and has encapsulated why your interest in this area?
Um, Interested in dementia in particular, or interested in like the whole end of life? Um,
Either or.
um, So, I mean, I think my grandmother was sort of the first introduction around dementia. My father-in-law actually died about 2 or 3 months after I joined Compassion and Choices. I've been here now a little over 9 years, and I was the chief program officer at the time. And I just went through the training around like how to help a person who's dying. It was like, just fresh out of my mind, and he ended up with stomach cancer, and I went down to be with him just before he died. And he was really thoughtful and clear about what he wanted. He ended up with stomach cancer that he had gotten at the very last. Well, he didn't know he had stomach cancer, and it was like a late diagnosis. And um, he was so clear about what he wanted that it and he was still able to make decisions for himself, that it had such a profound impact on the family. And watching him say goodbye to people, he actually had his 80th birthday, transferred from the hospital to hospice care, lived through his 80th birthday. We had a big party for him at the hospice, and he died right after that. And it was an incredibly powerful exit from a really powerful life. And that was something that has stayed with me in terms of why this work matters. That to see the thoughtfulness by which he actually planned out his whole funeral as well. Like he planned it out to the very end. And it was the family wasn't fighting over, they fought over how to execute what he wanted, which was not easy. He wanted 3 choruses to come together in Baton Rouge and sing the most challenging songs, which they all made happen. It didn't give anybody time to argue and fight amongst themselves, because they were all so focused on how do we make this vision our father has come to life. It's left a huge impact on me.
That's a great story. I can imagine, these types of documents and these types of conversations, the takeaway that I often have, in doing this work is that it gives patients and families a modicum of control against the disease that often involves, taking a lot of control away.
Yeah. The other thing that I'll just add is I was just authored an author of a chapter in a book that just reached the bestsellers list called Plan a Life You Love. And my chapter is all about the lessons I've learned from our terminally ill advocates. And when I first came to this work, my greatest concern was that it was gonna be really hard to be around people who were dying all the time, and how would I handle that emotionally? And what I came to find is that the people who embrace that they are terminal and live their life fully until the end have an incredible amount of impact, and they can teach you how to have a more powerful life each and every day. So I detailed out the lessons that I've learned from them in this chapter, and part of what I try to do is take the blessing from getting to be a part of their, really difficult experience and try to live my life in a more impactful and meaningful way. And it's things like being courageous, even when it feels like you shouldn't be courageous. Because if you think about, I may not be here tomorrow, it no longer seems very scary to do whatever it is that you were afraid of doing. Same with, every time I'm about to get really angry at my husband over the fact that every time I go out of town, I come back and there's dishes in the sink. I think about, like, at the end of my life, am I really going to care that my husband constantly left dishes in the sink? Or, is that what's important? Is that the battle I want to pick? Or is that just, do I just decide I'm going to do the dishes because we've been married for 30 years and that's what's going to happen? And it really has taught me how to live my life differently. And it's been such a blessing, that I think there is opportunities for people to assess their lives based on an awareness of our mortality.
I can imagine it certainly helps keep things in perspective.
Absolutely.
All right, so just wrapping up really quick here. So Bruce wants to say this has been very good. Thank you. He wants to show it to a friend. Is the recording available online? Yes, the recording will be made available on the Dementia Caregiver Support Program website. I believe the link was sent through the chat before, but we'll be happy to put it down in the chat again if you missed it. But yeah, so give it after about maybe a week or two, the recording should be on there, so be on the lookout. Okay. All right. So the last question here, while we have a little bit of time left, Tamara asks, if somebody is suffering from a terminal illness like cancer and has dementia, can one choose to end life in a state like Massachusetts, which does not have legal end of life choices?
Yeah. So if you can choose not to treat your cancer, but you couldn't choose to take a proactive measure to end your life legally, which you also couldn't do if the person had dementia. You also couldn't do it in any of the states that have medical aid in dying, because all of them require mental capacity as one of the core safeguards.
Okay. Maria says, thank you very much. It's been clarifying, helpful. I appreciate your very specific guidance and will spend time with your resources online. So thank you, Maria. And with that, I think we are all set with questions. So just want to remind everybody that you'll receive an email. We would very much appreciate filling out an evaluation for our presentation on our discussion tonight. Any feedback helps, so we'd be greatly appreciate it. Judy has been nice enough to put our website, dementiacarecollaborative.org, down here in the chat. So please feel free to visit that to see a recording of this presentation, as well as all the other ones that we've done in the past. There's a lot on there, so a lot of good information and a lot of good presentations. So Kim, I thank you so very much for joining us tonight. This has been an amazing discussion. And for everybody, thank you for joining us here at the Dementia Care Collaborative. Hope everybody has a great night, and we'll see you at our next presentation in about a month. So thank you.